Okay, by my watch, it is 9:30. So welcome, everybody, to the third annual Texas Public Health Summit. My name is Janelle Rios. I'm a faculty associate at the University of Texas Health Science Center at Houston, and I'm over at the School of Public Health. I also serve as a deputy director for the Texas Epidemic Public Health Institute, also known as TEPHI, and I have the honor of being your MC today. So to encourage us to take our seats and keep the program running on time, I'm raffling door prizes. And yes, you must be present in the room to win. So please take a look at the raffle ticket that's tucked very neatly inside of your name badge. I'm going to read the last four numbers of the first winner of the first door prize. Speakers, we didn't give you door raffle tickets. Sorry, speakers. You got a speaker gift instead. So the first winner is number 2267. 2267. Going once, going twice. Okay. The next number is 2186. 2186. Yay! What's your name? Leah Griffin. Congratulations. A mug, two mugs. They're TEPHI mugs. The last prize of the day is the best one, by the way. So today's event is very popular. It's more popular than what we anticipated. And parking has become an issue in our very handy parking lot across East Road here. So if you parked illegally, we're going to take a short break after the first speaker so that you can move your car, because I'm told that UT Police Department will tow. No, they're not going to tow. Oh, good. Okay. Through the magic of Safety Bob and his wonderful relationship with the chief of police, Chief Adcox, those cars will not be towed after all. Okay. 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 As long as you're parked in an end cap or where there's some hash marks, so you're not impeding the flow of traffic. So excellent. Thank you so much, Bob, for that. Okay. So now that I have your attention, please allow me to share a few housekeeping items. We are recording today's summit, and some of you may appear on camera, so we're going to make you famous. So the recording is going to be available in a few weeks on the TEPHI YouTube channel. Stay tuned for that. If you registered in advance for the conference, you will get an email with that link directly from us. We have many continuing education credits attached to today's summit. In order to receive these units, however, you'll need to complete the end of the day survey. I'll show a QR code at the end of the day. The QR code will take you directly to that survey. Also, if you registered it in advance, at the end of the day, you'll get an email with a link directly to that survey. Now, we are so popular, we have over 500 people joining us online. For those of you joining us online via Zoom, you may pose questions by typing your question into the Q&A window. We have a moderator for the Q&A window who will compile your questions and ask them at the appropriate time. Please don't use the chat function. We're not monitoring that one very closely. It's much easier for us to organize the questions when everyone uses the Q&A window. Also, you may turn on closed captioning by clicking the button labeled CC at the bottom of your screen. Now, for those of you joining us in the room today, the restrooms are located out this back door where you came in and to my right. If we need to evacuate the building due to an emergency, please exit the doors immediately behind you. This afternoon, we'll provide lunch in the foyer right behind this back wall. Additionally, and this is very important, We'll have coffee flowing freely throughout the day, so please help yourself. If you happen to park out in this very crowded parking lot, you should have received a parking voucher when you came in through the check-in desk in the front. If not, please see Linda at the check-in desk for your Parker voucher so you can exit without having to pay a fee. Finally, before I introduce our next speaker, I'm shining a light on the partnership with the Texas Department of State Health Services, because much of TEPHI's work, including today's summit, is the product of a wonderful collaboration. I offer a special note of thanks to Dr. Carlos Plasencia, and I saw him earlier. Where are you? There he is, over there. And to Dr. Brendan Sullivan. I thought I saw him back over this way. There he is. Thank you, guys. You both worked really hard. You sparked some wonderful ideas and you helped us secure speakers, and you did so much more than that. I also offer a hearty thanks to the TEPHI employees. You'll see them in blue shirts so you can spot them easily, and especially if you have a question. They've worked very hard to produce the show today. I'm also grateful to our speakers and to you, the audience, in this free exchange of ideas and expertise, and all in the service of our fellow Texans. So with these housekeeping items out of the way and my gratitude shared with you, it's my great pleasure to introduce our first speaker. Eric Boerwinkle is the Dean and M. David Lowe Chair of Public Health at UTHealth School of Public Health. He's my boss. He joined UTHealth Houston faculty in 1986 and served as chair of the Department of Epidemiology, Human Genetics, and Environmental Health at the School of Public Health from 2003 until 2015. He also directed the Human Genetics Centers at both the School of Public Health and the Brown Foundation Institute for Molecular Medicine with UTHealth. Dr. Boerwinkle has led groundbreaking research on the connection between genome variation and the transition from health to disease. During the COVID-19 pandemic, he led teams of analysts, clinicians, and scientists answering COVID-related questions locally in the Texas Medical Center and across the state in collaboration with the Texas Department of State Health Services. Additionally, Dr. Boerwinkle serves as the principal investigator of the Texas Coronavirus Antibody Response Survey, known as Texas CARES. He is also the TEPHI agency director, the state agency charged with creating a trained multi-sector public health reserve network across the state, and the primary sponsor of today's event. Please join me in welcoming Dr. Boerwinkle.
I'll be brief. You all didn't come here to hear a dean speak. So the most important thing I have to say is good morning, and thank you all for being here in person, and also for those that are joining virtually for the third annual Texas Public Health Summit, brought to you as a collaboration between TEPHI, as you just heard, at the UTHealth School of Public Health, and also the Texas Department of State Health Services. When we set out to host our first summit in 2022, our purpose was really simple, and I mean that: to establish a forum for in-depth discussions and focused discussions on a single urgent topic relevant to current public health. This year, we're highlighting zoonotic diseases, which according to the World Health Organization accounts for about 60% of emerging infectious diseases globally. This figure and the unique urban and rural ecology of Texas underscores the critical importance of preparing Texas communities for infectious disease outbreaks by addressing zoonotic threats. We hope this event will inspire new discussions and foster connections that enhance the health of all Texans. I want to extend my gratitude to Dr. Carlos Plasencia, Medical Director of DSHS 65 South. Dr. Plasencia's team were crucial in planning this summit. And the reason I wanted to call this out for the second time is having the partnership, it provides a vital perspective that goes beyond what a purely academic committee would offer. I also want to take time to really to thank Janelle Rios, who just was up here for her leadership in organizing today's summit. With that, it's my great pleasure to introduce Dr. Paul Gruenwald, the Director of Disease Surveillance and Epidemiology at the Texas Department of State Health Services, who will open today's summit and give us our keynote address. Dr. Gruenwald began his professional career in 1998, working as a practicing veterinarian, especially in critical and emergency care. He moved on to becoming a zoonosis veterinarian for Harris County Public Health in 2004, after completing his master's in epidemiology at UTHealth Houston. No wonder you're successful, gosh. In 2006, he joined the Texas Department of State Health Services, and in 2020, he transitioned to Austin in a new role as the state public health veterinarian. Dr. Gruenwald's impressive career is a testament to his unwavering commitment to public health and animal welfare. So please join me in extending a warm welcome to Dr. Paul Gruenwald. Paul.
No, the slides built in, or you're going to bring them up? Okay.
That was you.
That's me. All right, so just go forward. All right, well, good morning, everyone. I'm not going to say I'm not a little intimidated. You've got a lot of very smart people here looking around the room that I've worked with over the years, and there's a lot of experience. And so I'm going over some things that there's quite a few people here that know about more of this than I do, but I'm just trying to touch over a couple topics that we will get into more later. You've got some good panels. We're going to be discussing some of the things that we have going on in Texas. You have a great opportunity to ask questions. So I'm just going to do a kind of a brief overview, touching on some very specific topics that I think, in my mind, are some issues that are emerging issues in zoonosis control in the state of Texas. So this is me. Want to give just a brief overview of who we are as zoonosis control, what that branch does, and how it's divided up in the state. Give a little bit of explaining of kind of what the state of Texas, how we're split up, what our authority is, and then go into some of the work that we do, talk about the oral rabies vaccination program for those of y'all that haven't heard about it, some of our projects and some concerns that we have going forward. I'll touch on flea-borne typhus, just because I think it needs to be talked about, and I'll explain why, and then go over a few emerging diseases that may be of interest that need to, I think, we're going to see going forward. Okay, zoonosis control branch overview. So on this map, they mentioned Dr. Plasencia is from 65 South. So you can see on here, 65 South is Southeast Texas. And so the state is divided up into 8 regions. It's a very big state. They're all different. They're all very, very different, and they all have their own personal political situation of how things need to get run. The blue parts of the map, those are counties that have some degree of local health department, health entity, somebody that oversees part of the public health response in those counties. It's going to really vary based on the county. Every county is different. The amount of money that's put into the public health, the community, the leadership that's there. And so saying that a Houston or Harris is stronger than even some of the smaller counties like a Matagorda or an Orange County is not realistic, in a way that, yes, they may have more resources, but when it comes, and I'm going to bring this up a couple times, when it actually comes to doing real public health, it's the personal relationships. So even me, when I was in 65 South, I can't just go up to Huntsville, and you can see that's in the very top county, Walker County, and show up and say, I'm from the state, come talk to me. It's going to be relationships. When I knock on the doors, they're going to open them because I brought somebody with me that's a nurse that they know and they recognize the face. And this is where the local health departments are so critical, because they develop those relationships that are going to get the doors to open. Zoonosis control, we're divided into 8 public health regions. They have a veterinarian in each region. It's a very important resource that Texas has that isn't shared around the rest of the country. We're very blessed to have that many veterinarians. We've got the program specialists and support staff, and then we have the central office staff that has their own, the work that they have to do. Okay, I just wanted to talk on this a little bit because this may come up later when we start talking about H5N1. What gives us the authority to do what we do? It has to be spelled out in legal code. It's not just, we want to save lives, therefore we can go in and we can take something from your property because it's a public health risk, or we can trap mosquitoes on your property, or we can talk to you, or you have to get a vaccine. Everything has to be enabled in legislative code. And ideally, it's gone through well-worn paths of, we've done this before. The lawyers have already looked at this. They're comfortable with what you're doing, and you can go forward. It's going to be spelled out in Chapter 81 of the Communicable Disease Act, which does sound like there's a lot of enabling legislature that gives us a lot of authority, but in reality, we need the people to work with us. So if somebody does not want to go into quarantine or go into isolation or not do something that we say is a public health risk, it's very challenging to get them to stop. And the one situation where we used a lot of control orders was with tuberculosis. Frequently, we were writing orders of, you have this infectious disease. If the person didn't want to take the treatment or stay at home, I mean, there's not a heck of a lot that we're going to do to force them to do that. And, you know, working in the rural communities, the nurses would call and say, hey, I saw so-and-so at the Walmart. I know they're not staying home. Well, we had situations where we would try to get them to have to go to the TB hospital in San Antonio. And there was one situation in particular, we were working with that person for well over a year to convince the local health authority and the legal judge and the lawyer that this person was a public health risk. So if we think about our infectious diseases, a year, the incubation period and quarantine period is over with for most of our diseases, and they're no longer a public health risk. So saying that we want to use these laws to force people to do things, by the time you get through legal, they're no longer a risk. So we really, really want to work with people. And I go back to, that's where those personal relationships are going to help. And we need to have those. Because we're talking about zoonosis, I'm just going to mention the Rabies Control Act. That is what gives us the authority to do with a lot of the work that we do on rabies control. And I'll give you some statistics when we talk about cases. Right? Rabies is really just one of those sexy diseases that we're not getting a lot of people that are dying of rabies. Fortunately, we don't want that. We've had that. We don't want to go back there. But it's a scary disease, so it tends to get a lot of attention. So some of our key control activities that we do, and this is where you have these veterinarians and the staff that they work with, are going to be consulting with anybody. The trick about zoonotic diseases is they have that component by which you have to pull in a cycle of the virus or the bacteria involved either in the environment, in a vector of some kind, or in an animal species. And that can be confusing because it seems like the disease fairy comes along and bam, you've got West Nile. It doesn't really work that way. And so where these people are important, they can look at, okay, well, I was out after a storm and now I'm being bit by a bunch of mosquitoes, therefore I'm going to get West Nile. Well, it depends. You know, there's certain mosquitoes that carry West Nile. The likelihood of the floodwater mosquitoes actually giving you West Nile. So there's other factors that are important with the zoonotic diseases that impact a person likely to get infected with a zoonotic disease that we want these teams to be able to speak to actually talk about the true risk. And the other one thing I wanted to mention on here is the One Health group. And this is a One Health collaborative, people coming together to talk. This is kind of a disparate group of people that normally don't work together. what is so important is having those initial conversations. We may all be speaking English, but the languages we use are different. The terms that we use, the things that we stress, the little, it's kind of hard to describe, but when you're talking to somebody and they're coming from regulatory and they have their rules and they know the things that they normally say, you show up, I show up as an epidemiologist and I'm talking my world, we're not talking the same thing and we don't necessarily trust each other. And so that where I'm willing to share information with you and you're willing to share information with me and we can work together. So having these One Health collaboratives before an outbreak happens or before you have a case of something really weird really helps things go very smooth. So then you can inform the community. You can talk to your judge or your commissioners, or you can do whatever you need to do to tell the family, whoever needs to know, this is what's going on. This is how we need to respond. This is the way that we can keep people safe. Okay. So for those of y'all that don't know, just quickly, what are zoonotic notifiable disease? I mentioned it a little bit. These are conditions that are they are either transmissible from animals to people or via a vector, or there's ones that we may share in common. Anthrax, I went with anthrax because again, it's another sexy. Zoonotic diseases are really sexy for the most part. People like them. They're scary: plague, anthrax, rabies, I mean, they're just, yeah. Flu is not so much. Now it is because we're dealing with the dairy cows, but we'll get into that later. But this one, so we talk about the vector-borne diseases. That's the big one. The select agents, I mentioned a few of them: plague, anthrax. It seems like it was when I first started, we were dealing with the powdered letters when the anthrax was put in the mail. I don't know that they ever figured out what it is, but it was in Texas. We've had anthrax for years. And so it wasn't a weaponized agent. It's in the soil. It's here, and you can, on this map, you can see the counties are where we actually had cases, animal anthrax cases, in that triangle between Ozona, Uvalde, and Eagle Pass. That's typically where we tend to see most of our cases in animals. And it pops up not uncommon. Usually every year we'll get cases. And this is just the pictures here to demonstrate. We see that usually the presenting sign in animals is dead. They may be bleeding from the muzzle. They may be bleeding from other areas. But the ranchers know in that community, that's where they typically are going to see these animals. And this is one, y'all are going to get this slide deck when I'm done. So I've got a bunch of links on here for references that y'all can go to if you want to go into these articles. But this is a case where the person got skin anthrax. And this is a pretty angry little bug. And so it reacts very strongly in the body when you get it. And the body, you can see on the skin. So you can imagine if people were to get that in the lungs, what that would look like. It's pretty aggressive. But even with this triangle, we've had cases up in the Panhandle recently. So it doesn't always stay put and stay in that part of the state. So this is just an example of the way zoonotic diseases are always evolving in the state, and they move around, and they tend to keep us very busy. And the next one, this is the one I wanted to talk about with the different rabies cases that we have. And again, fortunately, there are very few. Suspect cases of human rabies are immediately reportable. And there's some very specific work that we need to do to test for rabies in people. There's some very, very specific samples that we need to collect. So anything that has to, if the CDC is going to test for it, there really has to be a reason to think that this person has rabies. We don't have them very often. There was one down here in 2006. I know Dr. Martinez was heavily involved. I was in Harris County at the time, and we were very busy responding to that one. There was one here in Bayer. It says Bayer County. That was potentially that person. We don't really know where that person was exposed. They survived. And the only reason that the CDC was willing to call it a case is because the person had antibody to the RNA in the CSF. And so they said they could not have been exposed to the virus through the vaccine. They had to have been through the actual virus, and their exposure was said, I went to a cave and I went to reach out and something flew in my face. Not a great interview person. They didn't want to give us a lot of history, and then eventually got better and was lost to follow-up. So it's so far as we know, one of the few unknown, untreated rabies survivors. The most recent one we was in 2021, and that one was in Medina County, and that person did have a known rabies exposure, had a bad exposure, and they didn't know to get post-exposure or even be concerned about bats. Now, that's not the case we have in animals. In animals, we have a lot more rabies. We have a lot of rabies. So let me talk through this map. This is 2023. So the two big rabies variants that we have in the state. Who has heard the term rabies variants when I say that? Not very many. Okay, so rabies variants, what that means is that virus is adapted to that specific species and tends to circulate in that species, and it moves within that. So bats that have rabies can infect other bats with rabies. And actually, we're talking species specific. So if you have Mexican free-tailed bat rabies, it's going to stick within the Mexican free-tails. South Central skunk rabies, it tends to stick within the skunks. It goes from skunk to skunk to skunk and passes on. Every once in a while, the closer that species is to another mammalian species, the more likely that there is to be spillover. So bat rabies doesn't often, it can, but it doesn't often jump from bats. We get a lot of bats, but we don't get a lot of mammals with bat rabies outside of bats. Skunk rabies is completely different. It's a lot more like mammals. It tends to jump into other species a lot more. And you can see this on the map. So looking at the red dots, those are cases of bat rabies in 2023. These are all in bats. You can see a nice little cluster here in Houston, Harris County. There's always a cluster down there in Lake Jackson, down there in Brazoria County. Kind of along the I-35 corridor there in Austin and San Antonio, and then there's some down in the valley and over in El Paso. But then you look at the rest of the state, and it's kind of a big hodgepodge. So the skunks, I talked about the other variant we have is skunk rabies. Those are the blue dots. And you can see we have blue dots on there, but they're buried with all the other stuff. And so the skunks that we're getting with rabies tend to be a lot around Central Texas and moving up into the Panhandle into North Texas. But look at all that other stuff. So those are all the other animals we had diagnosed with rabies. And the most common variant that they're getting is skunk rabies. You can see on there, we've got some dogs and cats. We've got a goat out there in the Edwards. A rabbit goat. What is that? Bovine, some horses. I mean, the concern, why make light of it, is because those are animals that people normally have contact with. And if you're a horse owner or you have cattle, you go up on your cow and the cow's choking. The first thing you do is you put your hand in its mouth to figure out why is there something in there that's stuck. Same thing with horses. Dogs, cats, if they're going to expose a lot of other people. And so those people need to be found and get started in post-exposure prophylaxis. And this is what the zoonosis team does. This is why they stay so busy. So one of the things that we have enabling legislature for this. So if people are potentially exposed to a rabies, what they go through is rabies post-exposure prophylaxis. And so even if they don't know that we have a rabid animal, if they were potentially bit by a dog, a cat, they were jogging in the park and something hit them in the head and it flew away and they don't know, could it have been a bat? I've got a red mark. We do an assessment. The staff does an assessment to see what was their exposure. Is it something where the animal's available for testing? And that actually does make a huge difference, so they don't need to go through post-exposure because the animal's there. You can get it tested, show that it doesn't have rabies, or show that it couldn't have had rabies in the saliva when it bit you, because for the virus to be in the saliva of that animal, it had to have gone through the brain. So they're looking for rabies virus in the brain. So if the rabies virus, they don't find it in the brain, that animal couldn't have given you rabies when you were bitten. And then if we can't prove that, or we find out that the virus was in the brain, then they do post-exposure, which is going to be, the term is on here, the post-exposure prophylaxis series, immunoglobulin, which is antibody that somebody else has made, that they inject around the site, and then 4 to 5 doses of vaccine. People can get this from their providers. Where we step in as a state is we're the safety net. So we can, if they can't find a provider that's willing to give it to them, then we can provide the vaccine we're still going to have to find somebody that's willing to administer it. And so these numbers are a little bit skewed because we really don't know exactly how much vaccine is given around the state or how many people are treated. But you can see, and this was in 2022, this was the last time that we have the full data set for this. And we were provided rabies biologicals to 147 people. Average cost was around $5,000, a little over $5,000. You know, when you look about medicine, it's not that expensive. Some of these drugs that are coming out now, I think the hepatitis C drugs are like $90,000 for a treatment. This isn't that expensive. However, this is not, we are going to be an out-of-network provider. So then the person that's getting these biologicals from us, this is not, they can't bill insurance for this. So they're going to have to find the money to pay. And so this can be very expensive. If you were bit, you were jogging in the park and something hit you in the head and now you've got a bite on your forehead and you don't know what it is. I don't know, let's go ahead and now I've got a $5,000 bill plus whatever the ER is going to charge. So anything we can do to stop from these people from having to go through post-exposure, we really want to do it. Okay, the other person you're going to meet later, I want to call her out, Leigh-Anne Lawton, our state medical entomologist. Other things that we do with to help for people in the state, we have two big programs. We do tick testing, so if people find a tick on them, they can send it in and we will identify, make sure that yes, it is a tick. That's not always the case. It is a tick. Identify what tick it is and send it off. We have a partner that we work with that tests them to see if they have any known tick-transmitted pathogens. And if they do, we let the person know so they can make a decision, work with their provider, and we'll consult with them to see if they need to start on some sort of post-exposure medication. The other one, which is a little more creepy, but I'm not going to get into Chagas. I know Dr. Hamer's here, and that's her world. But if people find, this is that one little bug in the top corner by the ruler, the triatomes. If people actually find triatomes in their house, they can send them to us. First, again, we have to verify that they're triatomes, and then we'll send them off. They'll test to see if the bug does have the Trypanosoma cruzi in it. If it does, then they'll do a blood meal analysis to see if there was any indication that the bug had fed on a human. And then we go from there to decide, okay, how much risk is there truly of you having Chagas disease associated with the bug. It's got a really, really strange life cycle by which the parasite, you're not going to get through the bite, it'll be in the feces. Unfortunately, we do get cases here in Texas, locally acquired cases. So the other picture that we have on here, which is more y'all should know about being here in Southeast Texas, is all the rains. After the storms, there's a lot of flooding, there's a lot of mosquitoes. A lot of mosquitoes. And I like that. I'm in Austin now, so I don't have as many mosquitoes and I'm enjoying it. But people are asking, can you spray? Well, yes, but what our target is, there's some requirements that we have from FEMA as for reimbursement, because there's just not a big pot of money to go out and spray. We have to work with the locals. I know Dr. Vigilant's here from Harris County. So again, this is a whole team that knows how to respond to a storm. So I'm not going to touch on that too much, just so that there's a lot of flooding. What we have to do is verify that the mosquitoes are truly a problem, what type of mosquitoes they are. And this one picture in the middle has got, these are the when they did trapping prior to spraying, those are the mosquitoes they trapped one night. I don't remember if it was what county it was, Hardin or Liberty. Both of them. Okay, so a lot of mosquitoes, which is to be expected after a storm. You spray, you target your areas where people are going to be impacted, and then test afterwards to make sure that it actually worked. The spraying worked. That's another thing that the zoonosis team does. And then they do the field surveillance. And so this is a team going out. This looks pretty dramatic with the moon suits. This would mostly be for hantavirus. And then they're doing some tick drag right there in the middle with the white flag. Okay, let's move on to the ORVP for the All Rabies Vaccination Program. This has actually been a very, very successful program. It was started in 1988. The issue was, I've talked about skunks and how you can see what the skunks are doing in terms of transmitting rabies to other species, the dogs and cats and goat. The Ones that we're a little bit more concerned about are going to be fox rabies. Rabies in foxes, they tend to become more aggressive and they tend to go after other animals. Bat rabies, when they get them, they tend to just drop. They tend to have more the dumb form where they just go off and die. I used to live by one of the White Oak Bio, and they had a big bat colony when I was here. And everyone I go running after work, they would be zooming out to go feed, and they would go right over my head. And I'm just like, please stay, don't hit me. They never did. But there would be times when I would be running underneath, and there would be a bat on the side of the bridge, and so I'd get a stick and flick it over into the bio. So nobody would touch it. But that's what often bats do. Coyotes don't do the same thing. They tend to be aggressive, and they tend to go after people or animals when they get rabies. And I had a nice video, but I didn't have time to include it. But what you can expect. A rancher had taken a video of a fox who's normally a wildlife that wants nothing to do with people, is in his yard, and as soon as the guy opens the door, the fox charges at the door because the fox is trying to bite him. So fox rabies is one of them. Coyote, that moves over into dogs really, really easily, and we love dogs, and the more dogs they come in contact with people, so that's a problem. So this outbreak was going on in 1996, and what we did was we partnered with the U.S. Department of Agriculture Wildlife Services to start dropping vaccine that we know works in this species. So with coyote and foxes, we have an oral vaccine that we can use to vaccinate these animals. And so here's the two rings, the coyote vaccine zone. This is all down South Texas, and we're on Dr. Tyler's region. And then you have the blue kind of semicircle ring. That was where that was in West Texas, and we were vaccinating and trying to start around the ring and then move our way in. And so this is where it started in 1995, 1996. And this map is where we went in 2024. So we've pushed coyote and fox rabies out of Texas. It's no longer here. We're not having any cases. And you say, well, how do you know? Well, what we do is what the lab does is that if we get a case of rabies in an animal, they do the typing to see what type it is, and we're not getting any coyote or fox rabies anymore. And so on this graph, you can see where we started. The ORVP, that's the yellow bars. That's when they started dropping the baits. In around 1994, there was a pilot test. 95, they started, and I don't remember if it was coyotes first or foxes. I think it was coyotes first. And then 96, they did both of them. But you can look at the dotted orange line. Those were our cases in domestic dog coyote. And then the gray fox, I talked about how aggressive it is. Look, in 93, we were around 50 cases, and the next year it shot up over 250. It tends to move very fast. And so I'm gonna show you why that's important later. And then it started petering out as the vaccine started working, and by around 2010, we didn't have any more cases, and we haven't had any cases since. So it's working, and we want to keep it that way. Let me show this little video. I was going to show these pictures, but I got a video. So let me see. Can I just see what this does? It's embedded. Volume.
Today we're in Alpine, Texas, completing the third leg of the 2023 oral rabies vaccination program in Texas.
So we're conducting the oral rabies vaccination program to mitigate the introduction or reintroduction of rabies variants into Texas.
The state of Texas has been working with USDA for, I think, a couple decades now to drop these little baits with rabies vaccine in them, primarily targeting canids like foxes and coyotes to try to keep the canine variant of rabies out of Texas.
We plan the flights, I draw the grids, transfer them to Blackhawk, which is the USDA software, and from there we schedule flights, run reports on the costs, how much fuel, the baits, incidentals required for the trip.
So this year we're baiting somewhere between 800 and 900 miles of the border. The project this year is about 16,000 square miles. We're going to be dropping a little over 800,000 baits.
This requires months and months of preparation. We've got to figure out what grids we want to use, how wide they'll be, what kind of flight lines we want, how much vaccine are we going to have.
We work very closely with federal partners in the U.S. Department of Agriculture Texas Wildlife Services, Texas State Guard, and we rely on their expertise and the knowledge and training and equipment that they bring.
After we drop the product on the ground, 30 days later, we will test our target animals, our coyote and fox, to see if they are actually taking this vaccine.
So these vaccines are designed for use in wildlife, not for domestic animals. So if your dog were to eat one of these packets, we would not consider your dog legally vaccinated for rabies.
If you come across one of these packets in the wild, first and foremost, don't touch it.
We would ask that they leave it in place. I mean, that's the point of the program, is to get these baits out there so that wildlife that we're targeting can access these baits and become vaccinated. ORVP has been in operation since 1995 for the South Texas part of the project, which was targeting coyotes predominantly, and since 1996 for the Texas fox part of the program, which was West Central Texas.
It's definitely a big change of pace to be a part of ORVP. It's nice to be able to get out into the field and do a little bit more like applied public health. And yeah, it's a very interesting program that's been like very effective. So it's really an honor to be a part of that.
It's really a lot of fun and a pleasure and an honor really to work with all these team members from other agencies.
The money was well spent and we accomplished our goals.
That we have managed to eliminate 2 major terrestrial rabies variants. I'm very honored to be a part of this program.
One of the I don't know if y'all noticed, is that maps we're going through, there was a big green blob more towards this area that was around Fort Bend County. There was a pilot project we did looking to see if it worked so well in coyotes and foxes, can we do the same thing for skunks? That's the big issue. Turns out skunks are not as interested in the packets, so it didn't work. They developed a product to see if skunks would take it up, and they wouldn't ingest it, and there wasn't an indication that the skunks were developing antibody. But the Zoonosis Control 65 South team, and I was there at the time, and so I got to go out and trap skunks. Different experience. Don't need to do that again. All right, so what's going on with ORVP that we are watching and we're a little bit concerned about? Okay, so I talked about the fox variant and how aggressive that can be. There's 2 maps here. The one on the right is, that one is talking about why do we maintain the border zone? The issue is there's not a heck of a lot of people that were, particularly domestic dog rabies being diagnosed in Mexico. It's actually a lot further down. It's not right on the border. The issue is we don't have any good wildlife data out of Mexico. So we within the past, I mean, these are kind of old. This little map, we've got one case that was a domestic dog case in 2011, and then that was in 33 miles of border down near Zapata County, and then one near Starr County, about 40 miles of the border from, or 80 miles from further down in Starr County. But we just don't have any good wildlife data out of Mexico. And then recently, as we were applying to the 2025 ORVP, USDA came back and said there's some concern that they're hearing out of Mexico that potentially the domestic dog variant is more prevalent than what they had previously suspected, which is why they want to be a strong partner with us this year. And I'm going to show you the map in a minute because we're having to expand it to make sure we get the entire border covered. But more concerning is what we've got going on this other map that has New Mexico, and we've got actually Arizona gray fox rabies moving over from Arizona. And it is already in a couple counties. We know it's been diagnosed in a couple counties in New Mexico, and the suspect is right there, Doña Ana and Otero County, that it's already there, which El Paso is right there. And this is an area that's never been baited. So you have a large population, a large stray animal population. And so we're trying to get funding for this with the legislature, but we worked with USDA, and the plan is found money. We've managed to get some funding that we're going to go ahead and bait the entire zone. So we're going to add, we did the blue part in 2024. We're going to go ahead in 2025, add the yellow kind of, it's kind of a yellow color piece around El Paso up above the Guadalupe, the north part of that, right there on the border with New Mexico, Guadalupe Mountains, and over into Loving County. Just because we have to do something, because it's that fox is moving very fast. It tends to move very fast along rivers, and we need to get some vaccine out there and try to start getting that population vaccinated. And then the other thing we're kind of watching and we're very concerned about is I blew up this map. This one is looking at particularly the skunk and the other different species that getting skunk rabies around central Texas and along the Colorado River and then the tributaries that feed into it. You can look at this. The yellow dots are skunks. Look at everything else. So the question is that rabies virus adapting such that it is now passing fox to fox and raccoon to raccoon? The nice thing, the big issue we don't have raccoon rabies in this state. That's a big issue on the eastern seaboard. Raccoons are very cute. People feed them. They have those cute little hands that can pick up dog food. And people like that. And so we don't want raccoon rabies here in any way. And so what we're trying to find out is, could the virus be adapting that it is passing raccoon to raccoon? We don't have enough samples. We would need to collect a lot more samples and work with the CDC to figure this out. We don't have funding for that. That would be one of our projects that we would like to do. Okay, let me jump off of rabies. Into flea-borne typhus, I just want to mention, we're on the downward slide. The flea-borne typhus, I want to bring this up because this is a significant issue in Texas. How many people have even heard of flea-borne typhus? Okay, we've got a few. Good. All right, so the word's getting out. It's a rickettsial organism. The primary vectors are rat fleas and cat fleas. The issue with this one is it's not the flea bite as well. It's going to be in the feces. Incubation period is about 1 to 2 weeks. So the transmission occurs is when flea feces actually get into the wound. It's not necessarily the bite. So if anybody's worked in a shelter or worked at a vet clinic or anywhere you have a lot of animals or strays, there can be a lot of flea feces on these animals. They don't actually have to have fleas, although if you got flea feces, you got fleas. Inhalation of dried rat or cat feces, that's a possibility as well. The thing is, these people get really, really, really sick. They don't just they don't have a mild presentation. The cases that we're getting, and I'll show you a slide in a minute, 70% of them are ending up hospitalized. So these cases, these people end up, they can have clotting issues, they can have problems with their liver, and this is not something that a lot of practitioners know about. We're trying to get the word out, trying to recommend testing. If the people work in a vet clinic and they know I may have been exposed to flea-borne typhus, they can mention, could you test? Because they would have to start on the specific antibiotics for that. Here's the graph of what we've had in Texas. And then you can see this was a big problem back in the 40s, and then along came DDT and a lot of rat control programs. And the cases really went down. And then you can start looking in the early 2000s, they went back up. And here we are sitting in 2022, and we're back at the level we were in 1950. We don't have DDT anymore. We're not necessarily having a big rat problem, but it's obviously adapted to the species we do have, and people are getting sick. This is where we're seeing the cases. The 2023, the provisional data, I think we had over 800 cases. 70% are hospitalized. We've had 33 fatalities so far. You can see where it's at. Not surprisingly, it's down in the valley, in Nueces County, areas where we have a lot of people, where we're going to find the cases: Bexar County, Travis County, Austin, San Antonio, Houston, and then up in the Metroplex. There's been a couple press releases about this, particularly in Tarrant County. There is efforts to try to get the word out. So any students, anybody here that is going to be wanting a project or wanting to do this would be a great thing, because it's not trying to figure out what the cycle is here in Texas and how is it spreading and what people need to do to protect themselves. This would be a good. We don't have a nice clean packaging like we did with West Nile or the 4Ds, or now I think we're down to 3Ds. But there's something catchy that you can make. We don't have that yet developed for this disease. Okay, I think I'm doing good on time. Let me just run through a couple emerging diseases, and I'm going to kind of go with a different perspective. There's just 3 of them here. But since I'm a zoonosis veterinarian, this is some red flags that I say, ooh, this is interesting. Okay, Mpox. This is not, for the most part, what we're dealing with now is a zoonotic disease. Why I wanted to bring this one up is to make sure y'all understand there's two different clades of this disease. Clades are just kind of like families of the disease. One, clade 1, which is in the more central, eastern, central part of Africa, and clade 2, which is in the western part of Africa. The subclades, it gets even more complicated, 1A and 2A are known to be zoonotic, where animals can get it and they can infect people. We even had a case with a situation here in Texas and the United States where we had monkeypox with clade 2A. Right now, the situation with where has been established in the United States and we haven't gotten rid of it is clade 2B. And so it's a different clade. And that's passing mostly human to human. It's skin contact. It can be associated, men who have sex with men. Clade 1, the big concern 1B, is what you may be hearing on the news now coming out of Africa. Again, that's also contact. That one is more associated with heterosexual contact, but it's going to be skin contact. There's some very good guidance on here if you want to go to this on Mpox from the CDC. The information that I was running into and why I'm bringing this up is because you will see sometimes, actually often, where they lump these all together into one Mpox and say people can get Mpox from animals, they can get it from skin transmission, you can get it from sexual transmission. I say, no, wait a minute, those are three very different things. And for veterinarians, what it's talking about, they're saying, or people that work with animals, if you do any kind of rehab or anything like that, there's information of how you can protect yourself, but it's talking about animal-to-animal transmission or animal-to-human transmission, like the clade 2A, where the animals have it as the host and they give it to people, then they lump in human to animal, where the animals could potentially get infected and now they're talking about clade 2B. And then they talk about animal potentially as a fomite. Maybe your client has Mpox and the animal has it on their skin and how you need to protect your staff. So they've really lumped all this together into one group of PPE that you need to do when clients come in. And I was very confused. I wouldn't know how I would implement this if I was in practice. So just for y'all, I wanted to bring this up and say this, just know that it's out there. When you see these messages, there's a difference between clade 1 and clade 2, and there's a difference between the clades that can actually infect animals and can infect people. Okay, I'm going to talk just briefly about Oropouche, and I'm going to go with Oropouche. I'm not doing Oropouche. I'm not on the French bandwagon on that one, because all the cases are all in, Cuba and South America. So I'm going with Oropouche. The things I wanted to mention about that, and we do have a group coming up right afterwards that's talking on arboviruses. Just some concerns that I have looking at this is it has a normal clinical presentation to all the other arboviruses. We have West Nile here. Diagnosing it's going to be a challenge. Confirmatory testing is only available through the CDC. That takes a long time to get those results. So if you're a patient that's sick or a doctor that's treating a patient and you're waiting to get lab results, we have to wait till we get it back from CDC. It adds a lot of time. I think it can be weeks to get those results back. The other thing is they've had some concerns about vertical transmission, that's mother to baby, which is bringing back Zika, which was a lot of questions for women who are pregnant and their families saying, what do I do? I'm pregnant. I've potentially got Zika. I was in an area. What do I need to do for the ultrasound? What do I need to do to protect this child? What steps do I need to take I may have a horrible disease that may give my baby some birth defects. That was a very challenging time that we went through. If this Oropouche is going to even go in that direction, it would be concerning. The primary vector with this is the biting midge. I don't know a lot of those. I'm a Houston boy, so I know mosquitoes. But they're out there. We know we have midges in the United States, understanding that cycle. And you would think, well, this is one of the things I talked earlier. Humans are not the normal host for West Nile. It's going to be more of a cycle from birds to mosquitoes. And then we just come off to the side. The mosquitoes look for a blood meal. They give it to us, and we're considered a dead-end host. So understanding the cycle of what this is doing in South America, which is going to be different than what we do here and what's going on in Cuba. Right now, it's an issue in Cuba. what impact is this going to have in the United States? If the virus comes up here, what is it going to do when it comes here? What's the cycle look like here that it could be maintained? Culex is the mosquito that's associated with West Nile. So we know Culex likes to transmit and can successfully transmit viruses here. So that's a little bit concerning. Primarily found in South America and Cuba. I've got the link here. You can Google CDC and Orapuche and you can find all the cases. I think I looked this morning. What did I say? 74 cases so far. This have been diagnosed in the United States. They're all travel associated coming out of Cuba. We don't have a lot of information out of Cuba. We're not on good relations with Cuba. So what's going on there is a big unknown, but we want to know how that's potentially going to impact us. I was in Cuba for a week, visit with some friends and friends of friends that live there. So I wasn't led around by government people. So I got to ask questions and we got to see. And when I was there, it was right after Hurricane Harvey. And so again, this is a perfect time for mosquitoes. And there were no mosquitoes. One, there were people everywhere. People were out because the internet was at the squares. And so in order to get on the internet, people had to go to the squares and everybody was outdoors and there were no mosquitoes. And so I asked, well, why? Okay, I would expect there to be mosquitoes. And they said, well, because they were having a virus. They didn't know what it was. They just knew they were having a problem. There was a health issue. And so the government, because it's communist government, the government just goes in and does what it wants. And they had gone and sprayed. And so I was not being bitten by anything. So the fact that the government can do that, and yet we're still getting a lot of cases coming out of Cuba, there's a lot of unknowns as to how this virus acts in the environment and with the midges. And then the last one I just want to bring up, a lot of big words here that I don't know how many of y'all are going to know. Carbapenem-resistant Enterobacterales. This is kind of a catch-all group of bacteria. E. coli, Klebsiella is a big one. And carbapenem, we don't use a lot of carbapenem in veterinary medicine. But it's a class of antibiotics. Basically, these are bacteria that are multi-drug resistant. And when they show up, this is reportable in Texas. The CREs are reportable in Texas. The CDC doesn't really want all of our list of positive CREs. They just want to know a specific subset of them. But the issue is when we get one of these in people, there's a checklist of things that we have to do around infection control in facilities because we don't want it passing from patient to patient. It can set up in the facilities, in the medical facilities. So you have to go back and do it. There's a nice tool that's used. It's called an ICAR, infection control assessment tool, that you can go in to identify where that patient could have, how are they cleaning the room the patient was in? Are they sanitizing the equipment? All that exists for the human medicine community. It does not exist for the veterinary community. And we are starting to get reports, particularly these animals that are going to referral facilities. We are starting to get reports of animals that are coming back with CREs. Not that necessarily they got them from the people. We don't know. It's a big unknown. Typically, we don't see a lot of swapping of bacteria between animals and humans. It does happen. But we don't have a lot of experience with recommendations for PPE and how to sanitize veterinary clinics. I don't have a team of people that are going to be willing. We have a whole epidemiologist and infection control practitioners that can go into a facility, a nursing facility or a hospital and say, hey, you have a CRE. Let's see what you did. Here's what you need to do to sanitize. Here's how you need to do PPE. I don't have that for vet clinics. So there's a lot of the information. What we can do is make recommendations. And this is a veterinary standard precautions PDF that was put together by the National Association of State Public Health Veterinarians. And then the next step is how do you educate the owners and what risk do they have if your animal does have a CRE? How do you keep it from spreading? How do you keep it from getting on you? And what do you need to tell your doctor should you get a skin infection or some kind of infection? This is another area that I think is going to expand. That's why I wanted to bring it up today. And that's it. I stayed on time. Yeah. I don't know, do we have any time for questions? Are we done? 1 minute. Don't need to have any questions. Sorry.
Bring the microphone. Bring the microphone.
But
So the online audience.
Oh, yeah.
Just curious if they're spraying for mosquitoes in Cuba, would that kill midges as well?
I've got, and now this is, I can use the resource. I've got some wonderful entomologists here at this table that can, I understand it does work, how well it works, in terms of, is it actually going to go after the species? We don't know what species we would have that would be transmitting. We don't know what's going on in Cuba. If it was to happen here, would we be able to use spraying with the same chemicals that we use for Culex and that would control midges? As I'm looking over at both of them, we don't know. There's a few chemicals that are listed on the label for aerial, so possibly. We just don't have a lot of experience. That's the concern. There's big gaps in what we know what's going to happen should it come here. All right. Well, thanks, everyone.
Thank you so much. That was wonderful. Thank you, Dr. Gruenwald, for your insightful presentation and setting the stage as we launch deeper into zoonotic diseases. Next, I'm going to ask panel 1 to go ahead and come up here and take your place on stage. This panel will discuss mosquito-borne diseases. Please remember that this is a discussion in which we hope you will participate and add your voice. So for the online audience, we're going to have time for Q&A with this next panel. So as the panelists make their way to the stage, it's my honor to introduce the panel moderator, Ron Tyler. Dr. Tyler has over 15 years of experience in diagnostic pathology and public health. He has authored and co-authored numerous scientific publications. Additionally, he has been invited to present his expertise and experience at many state, national, and international meetings. He received his veterinary degree from Oklahoma State University and also holds a Master of Science degree from Virginia Tech. Please join me in welcoming Dr. Tyler. And stop sharing, right? Okay. Okay, so hang on just a second. Okay, that's it, right? Okay, excellent. Thank you.
Perfect. Thank you and good morning, Houston. I am so honored to be here because I get to moderate a panel full of my good friends that I work with closely on a regular basis. Dr. Gruenwald's speech was excellent, and I let him know this morning, you know, if I get complaints about me, that I always point out that Dr. Gruenwald hired me. And then I was standing next to Dr. Abdul, and he's like, well, yeah, but I made up for my mistake by hiring Dr. Abdul. So I need, before I introduce my distinguished panelists, I need a volunteer, someone that speaks Spanish. Does anyone speak Spanish here? ¿Hablas español? All right. My question to you, we're gonna need a microphone. I'm gonna wait till I get a microphone run all the way back there. No rush. Ándale, ándale. How do you say dog in Spanish?
Perro,
How do you say little dog in Spanish?
un perro chiquito.
Or
Or what?
perrito?
Perrito. Okay.
That's okay. You'll see where I'm going with you. How do you say cat in Spanish?
Gato,
And how do you say little cat in Spanish?
gatico,
Gatito. So see where we're going? How do you say fly in Spanish?
mosca.
How do you say little fly in Spanish?
Oh,
We have a bit of an error in interpretation or translation. The word mosquito is Spanish for little fly, but they're not little flies. And the word for the mosquito in Spanish is zancudo, which is like long legs. All right, so let's get on to our panelists. I'm going to go from left to right. I'll start with our epidemiologist, Kelly Broussard. Do you want to introduce yourself and tell us about yourself?
Yeah, hi. Okay, it's on, right? Okay, good. Hi, everybody. My name is Kelly Broussard. I'm an epidemiologist with the Zoonosis Control Branch that Dr. Gruenwald just mentioned in Austin. I have been working in ZCB for about 9 years. And most of that time I've been working on arboviral diseases, but I've kind of worked on all of the fun, scary, gross ones that we have. So happy to be here on this panel.
And Dr. Christopher Vitek.
My name is Christopher Vitek. I'm a professor at the University of Texas, Rio Grande Valley. I've been there for about 16 years now. I sort of consider myself a Valley resident. And I primarily focus on mosquito biology and ecology. And I'm happy to be here as well.
So, and then Dr. Max Vigilant.
So hello, everyone. I'm Max Vigilant. I'm the director of Harris County Mosquito and Vector Control. I've been in public health for, how many people have been in public health for 42 years, 43 years? So that's me. I work in different sections of public health. So I oversee our surveillance section, monitoring Harris County, testing, and to ensure that we protect residents of Harris County.
Thank you. And last but not least, Miss Leigh-Anne Lawton.
Hi, I'm Leigh-Anne Lawton. I am the public health entomologist with the Department of State Health Services. Dr. Gruenwald also hired me, so.
Another redemption.
Now we're back.
Of that one mistake.
Yeah, and I've been here since 21.
Excellent, thank you. And I'm, traditionally trained as a pathologist, like I study hiking trails, right? That's a joke, bad joke, terrible joke. Never repeat that. But I don't know a lot about insects. And so these entomologists really are my working knowledge. And so when I'm like, oh, what type of bug is this? Leigh-Anne always saves me, or Dr. Vitek saves me. So we'll start with our questions that we kind of prepared. And I'll start with Ms. Broussard. What arboviruses are public health agencies currently monitoring in Texas? And are there any current outbreaks of arbovirus diseases in Texas?
Yeah, so in Texas, we have a series of routine surveillance methods, both in humans and in animals, to look for a variety of arboviruses. And they're broad enough that anything that is new or unusual, we might hear about it. But the ones that we are pretty much have standard practice, both for if you were to get sick and go to the doctor, we have passive surveillance is what we refer to it as. So testing that is positive for any arboviral disease from a commercial or hospital laboratory, that will be reported to us at the state. And that primarily our biggest nemesis is West Nile virus. She's very loud this year, so I'll tell you more about that in a minute. But West Nile virus is our biggest endemic arboviral disease. We also have some arboviral diseases that are also endemic, just less commonly reported, including the St. Louis encephalitis. We have other very unusually found ones, but they are there in the California encephalitis group of viruses. So there's quite a lot of variety and diversity in the arboviruses endemic to Texas. And then on the other side of the coin, there are viruses that we consider sporadically endemic or not endemic at all. And that would include dengue, Zika, chikungunya, and our new friend Oropuche. So I'm hoping she does not find a foothold in Texas. I call them all she because they feel somehow like they have personalities and I have to anthropomorphize them. But dengue has been reported sporadically, primarily in South Texas. And that is highly seasonal. It's usually in the fall. So Dr. Tyler will have a fun fall, I'm sure, this year.
Hope not.
And so that's something that we also do surveillance for the variety of people who are infected by travel. So when you go and look on our website or you hear in the news that there are dengue cases or chikungunya cases or Zika cases, those are almost certainly from individuals who went on a trip and got sick from being exposed to a mosquito bite in that other country. But we do always have to be aware that dengue, Zika, and chikungunya have all transmitted in South Texas at a variety of times. Dengue is the most common. So those are our main concerns for human surveillance. And then I mentioned mosquito or non-human surveillance. So that's primarily mosquito surveillance. So our awesome bug nerds here know a lot about that. Basically, people go out and set traps and they look for where they expect mosquitoes to be found. We identify them by species and test them appropriately. And there's pretty much routine surveillance for West Nile, St. Louis encephalitis, and Eastern equine encephalitis as well. So we have detected that in a few counties, Eastern equine, Usually it's in the eastern part of the state. St. Louis has been in just a couple of spots, El Paso and Lubbock, and then West Nile is all over the state. So the other part of the question about current outbreaks, this year, in 2024, West Nile virus activity in Texas is absolutely through the roof. And if you were to compare us to the rest of the country, if you go on CDC's website and look at the data, we are winning or losing, whatever you want to think of it. We have the largest number of human cases. Currently, it's at 64 total. I know that doesn't sound like a big number, but West Nile is a disease where only 20% of people even feel sick, and only a small percentage of those feel sick enough to be severely ill and seek medical care. And an even smaller number of those people are correctly diagnosed and reported as cases. So think of that as the tip of a giant iceberg. And the fact that we're winning that case number, that just shows you how much is going on. We also have the highest number of deaths so far this year, 6 deaths. We have the highest number of another form of surveillance. So if any of you, I'm curious, raise your hand if you've ever donated blood. A lot of people. Okay, so you've answered questions, right? It'll ask you, are you feeling well? Have you ever been diagnosed with this? Where have you traveled? So they use that information as well as actually just testing your blood. And one of the many, many things that your blood is tested for is West Nile. And so when that test is positive, that's reported to us. And usually when you donate blood, you're feeling well. You don't have a fever. You're not excluded by any of those questions. And so you're considered an asymptomatic person who has a detectable viremia to West Nile. And so those people are also a way for us to kind of get the temperature of how much West Nile activity is going on. And unfortunately, right here in Houston, it's pretty bad. There's a lot of viremic donors. So we definitely know that the Houston area is experiencing a really high level of West Nile this year. And then dengue virus is having a global surge in activity, and that is correlating to a higher number of imported cases for us here in Texas. So sorry, I probably talked too long.
We're going to go into dengue next.
Okay.
Don't jump the gun.
Okay.
I'm so glad she said oral puche or oral puche because she knows how to pronounce it. When I was reading it, I was like, oral pouch. And one time, I was talking with Nicole Everett and Kelly at Diseases in Nature conference, and I was asking them about a tick-borne disease. And I was like, have you heard about this disease, Powassan's? And they're like looking at like, what is he talking about? I was like, Powassan's is like up in Northeast, like Connecticut had a case. And they're like, oh, Powassan. I embarrass myself all the time. All right. Our next question is on dengue and malaria. Bad air, malaria, bad air. So there appears to be a surge in dengue cases globally. Is there a surge in Texas as well? And what are possible reasons why we are seeing an increase in dengue activity?
Yeah, so because dengue is my favorite, so I got excited and I talked about it first before we even got to the question. Yeah, the global dengue activity level is just really, really highly increased in 2024 and also the tail end of 2023. So there's a sort of a seasonal cyclical element to dengue in endemic regions because it's primarily more tropical or subtropical regions that are endemic for this disease. And so that has a lot to do with rainfall and temperature and the mosquito populations and the dynamics of that transmission. But one thing that really set off a lot of alarm bells for public health surveillance for dengue is that the normal cyclical pattern where it goes down at the beginning of the year and the colder times didn't go down, just kept going up, 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 up. So this is a global trend. The Americas are particularly burdened. Mexico is extremely burdened. And typically the patterns of local dengue activity that we see in Texas has a correlation to, you can think of it in terms of just adding more drops in the bucket. We have a local mosquito population, the 80 species mosquitoes that transmit that virus and others. So if you add more and more people who visited their grandma or their friend or went to work across the border and they got infected, they may not even experience symptoms, or they may be very mild, or as we all know, they may know they have dengue, know it's not treatable, and just shrug it off and wait to get better. That's a very common response for especially our border community. They might be very well aware that they were exposed to dengue. So that level of activity is kind of correlated to that increase that we see in our sister communities in Mexico. So we're definitely keeping an eye out for local transmission in Texas. And in terms of the why, there are some really interesting research that I've seen, especially in Puerto Rico. There's been a really, really outrageous amount of dengue. It's a really serious problem for them. And what they've noticed is, you all may be familiar that there are actually 4 different types, genetic types of dengue. They're dengue 1 through 4. And you can be infected with each one once. And unfortunately, each time you get infected subsequently, you get even more likely to be really severely ill. And what that means is when people are being exposed to a type that they have not seen in their lifetime or in the last few decades, then the chance of a lot of people getting infected and a lot of people being really ill is even higher. So in Puerto Rico, what they've seen is, I believe it's sort of a shift from dengue 1 and 4 to 3, maybe mixing up the numbers, but it's not really relevant. The point is that what they're having is a population exposed to a type of dengue that most people, especially children, have never been exposed to. And so there's a lot of people being infected just simply because of the dynamics of that immunology response to dengue. So there's probably a lot of research going on about weather, climate, all of the things that can impact mosquito populations and disease dynamics. But definitely that nuance of dengue complicates the way that we can detect human cases and expect that.
And for your information, dengue virus, chikungunya, Zika, these viruses are all transmitted by the mosquito Aedes aegypti or Aedes aegypti. It's a stegomyia species mosquito. And if you look at a couple websites, I wanted to give you information that have information about our mosquito transmitted diseases. www.texasmosquitoes.org. That's all different mosquito-borne diseases. And then www.txwestnile.org has information related to West Nile. But if you look at dengue data, you'll see we have a high incidence of dengue activity in South Texas, locally acquired or indigenous dengue activity. And that mosquito is very prevalent down there. It reaches close to 60% of our mosquito populations whenever people go out and trap. Whereas here, I would guess probably Culex probably is the superseding. We'll ask Dr. Vigilant to give us more details on what type of mosquitoes they catch on a regular basis. But the other thing about our dengue activity, and Kelly can probably attest to this, like when we start seeing activity, it's right around now to the beginning of November that our onset dates are in South Texas. So where Puerto Rico has been seeing it all summer long, we're going into kind of our heyday, or when we likely would start seeing it. So we'll see what happens this fall. But all right.
Wear your DEET, please.
I was right.
Yeah.
And then the other, so we're going to talk about malaria. Malaria, the questions I have is, are there any changes in the epidemiology of malaria in Texas?
Sorry, you guys have to hear from me. So I promise I'm going to let the rest of you.
I have plenty more questions, and we have a
it all
full hour.
planned out. So for malaria, there's been a pretty interesting pattern as of last year. So we were one of the chosen few states by the terrible fates to have locally acquired malaria. So us, Arkansas, Florida, and Maryland all got to be in this really fun club where Florida had, unfortunately, a handful of locally acquired malaria cases. So malaria is a disease that is considered eliminated from the United States for many, many, many decades. We do have the vector mosquito, Anopheles, but the level to which it is prevalent, sufficient to maintain transmission of malaria, that's a question that no one has a crystal clear answer to. And the fact that, I certainly raised my eyebrows when I read about Maryland, because I was like, okay, that's pretty far up there. But malaria used to be a common problem throughout the entire United States. Yellow fever had horrific outbreaks in Philadelphia in the 1770s. So really, mosquito-borne disease control now is not like it used to be, decades ago, but it's concerning to see activity of a disease we consider eliminated from this country, essentially with no clear way to predict exactly where we might detect the next case. Just like I mentioned with dengue, there's tons and tons of folks. Every year we have hundreds of malaria cases typically a year. These are all travel associated cases. So these folks are, you know, may have a detectable parasitemia in their blood. And if the right Anopheles bites them, and that can start a transmission chain here in Texas, that is the concern. And that is what happened in this case. And of course, it was Dr. Tyler's problem. It was in his region. So he had a really fun time last year.
I wrote for a lot of people. When I get a problem, I get a lot of friends to come help and
Yeah.
and save me again. And there was a question on the chat. It's www.texasmosquitoes.org, mosquitoes with an E, mosquitoes.org for the DSHS Mosquito-Borne Disease website. All right, so we're going to go on to skipping Dr. Vitek. We're going to Dr. Vigilant, and we're going to talk about monitoring. Dr. Vigilant, how do local public health agencies monitor for arboviruses? What tools are available to detect vector-borne disease pathogens in a community? And then what surveillance and monitoring tools would you like to see deployed more widely in Texas?
Thank you. So on monitoring for arboviruses, I would place 4 factors. Surveillance. The second one is surveillance. The third factor is sampling. Then identification. I'm going to leave the fifth one for another part, which is testing. So you need a structured foundation, a structured surveillance program where you want to find out what is in the environment, what vectors you're dealing with, where they're located, how can you collect samples for identification. And from identification, we're looking at, okay, are we going to test for which arbovirus? So I can relate that arbovirus to that particular vector, habitat, location, the time that the different times that that particular vector is present in the environment. So we look at, for instance, if we're looking at a dengue situation, so we have dengue situation in Texas, in Houston, Harris County, we're looking at Aedes aegypti, Aedes albopictus. Usually peak time of presentation is when the temperature is hotter in the summertime. So I won't see an event early in January, February, March when it's cooler. Well, with climate change, it's changing but I will see the changes when they start presenting March, April, May, down along the line. So the main part of this of monitoring for arboviruses, the concentration is having a structured foundation, a structured surveillance program. You know where you're going, you know what you're looking for, you know how to find it, and then when you find it, you're trying to identify what it is and relate it to the particular arbovirus that is transmitted by that particular vector. And then you can put a true surveillance program together for continuity and for continued monitoring. So when you have done that identification, collection, and sampling, now we want to test that particular species, that particular vector for the virus that we're looking for. In our situation, Harris County Mosquito and Vector Control, we test for dengue, chikungunya, Zika. We test for St. Louis encephalitis. We test for West Nile virus. We have 677 positive samples for West Nile virus this year. And your testing platform is important too. What you use as a testing platform. And before 2024, we were using ELISA as our test platform. We transitioned to qPCR, which gives us a greater picture of the environment and where we are, so we can work along that part. In terms of collection, we need to know what trapping is a major factor in terms of collecting samples. You determine which traps you're going to use. If you want to use passive traps or you want to use active traps, but you want to know the particular species you're detecting. And the question you ask about treatment and spraying, it depends on the species. It depends on the chemical that's specific to that particular vector. That's where we speak to the folks, to the chemical distribution people. But monitoring, you collect your samples, you determine what trap type you need to use for collection. So there are different species that will gravitate to different trap types. And your location of where you locate your trap is also important. Your time of collection is another factor. So all of the specifics have to be in place in order to monitor and collect. On the third part of the question, the number one thing I would use to monitor the program is education first, before I do anything else. Because one of the things that I think the major surveillance part is educating the public as to how they can help you to help them. We can do everything we can. We have when I look around, I see a bunch of UT professors that taught me public health. And I connect with a number of individuals that I know and online and through collaboration. But we can do as much as we can in terms of the research, in terms of collecting the data, disseminating the data around us. But if we don't use the public, if we don't do the public education, then we will lose that point. And that is why we struggle with certain aspects of disease and disease control, is because our public don't understand what they're dealing with. We know from the standpoint of where we are, that's why we're in the panel, right? But the public don't know what they're dealing with. So I'm gonna take the key point is education, and then I'm gonna follow back with our collection, our trapping, the different devices. Someone can bring up a new device or an active device that will be able to identify species, maybe do some AI work. But if we don't educate the public, we're still on the back end of the field.
Excellent. So our next topic we're going to cover is outbreak investigations. And I guess, I was thinking about trying to do this backwards, but I guess I'll go ahead and address like the first question is, and this is for myself and all of the panel. First question is, how are vector-borne diseases investigated and outbreaks identified? And I'll say, for the outbreaks identification, I work, the regional zoonosis control veterinarians or regional public health veterinarians work very closely with our zoonosis control EPIs in Austin, like Miss Broussard, Bonnie Mays, Brianna O'Sullivan. We work very closely. So when we're looking at an investigation at the local level, we're communicating with them on a regular basis. How are cases investigated? Healthcare, going back to Dr. Gruenwald's presentation, healthcare providers are required to notify local health departments in the Communicable Disease Act. And so, and laboratories are required, schools are required, veterinarians are required, dentists are required, a variety of different professionals are required to notify their local jurisdiction when they have identified disease of public health concern. And so the local jurisdiction usually gets handed the egg first, if you will. Sometimes it goes, we actually prefer if it's coming from out of the state to go to central office first, and then they go send it out to the regions that need to go, and then they send it out to the local health departments. That's often the case with laboratory reports, that are coming from California or Virginia or whatnot. And so the local jurisdiction gets the egg and they say, okay, is this an egg? They're like, am I dealing with this disease? And we have a mathematical formula that we follow to meet, to see if it's going to meet the EPI case criteria. And we work with our local epidemiologists on their investigation to see, do we have the clinical symptoms, clinical signs? Do we have any other laboratory data that supports our EPI case criteria? And then do we have the diagnostic test to meet that, thing that will put it out as a confirmed, probable, suspect, or not a case. Those are outputs in our infrastructure. When we're dealing with something and we identify something that I've never seen before, usually I'm on the phone with Kelly or Brianna, I'm like, what do we got going on here? We've not seen this, and this person has no travel history. First time we've ever seen that, then we're consulting with them, and they're looking at overall incidence rates, activity, and stuff like that. And so they help determine, okay, are we dealing with a true outbreak? And when we identify that we just do have a true outbreak. A good example with the malaria case. We don't normally see locally acquired malaria, and we saw a locally acquired malaria case last summer. And then I called in my friends and we did a response activity in response to that. So that's how it gets identified. The next questions I have are, how do public health agencies coordinate and work together across jurisdictions? Which agencies are involved and how do they interact with each other? And are there challenges, benefits, or with coordinating a response across jurisdictions? Before I go to other panels, did you have anything to add to what I said on how we identify cases and outbreaks?
No, I thought that was really good. I think it's important to remember for vector-borne disease especially, an outbreak is really a deviation from the expected pattern, and that's different for every disease. So anthrax, a human case in a place we don't expect to see it, we might consider that an outbreak. An anthrax case in the anthrax triangle with livestock exposure and 2 cattle deaths on their property, that's probably not an outbreak. So the definition of that kind of moves around depending on the context, and that it can be a really tough judgment call. And so that's also part of, I think, the difficulty of making sure the public understand the level of risk and what to be really concerned about and what, what's deserving of maybe a hair of their panic. Because I think sometimes panic is a response when it may not need to be, and it, undue stress on folks, they can only take so many precautions. So
You guys probably laugh if I called you up. Oh my gosh, I got a locally acquired typhus case.
I would try not to laugh.
We have typhus coming out our ears.
Yes.
All right, so the rest of the panelists, how do public health agencies coordinate work together across jurisdictions? Which agencies are involved? How do they interact with each other? And are there any challenges or benefits with coordinating a response across jurisdictions? Leigh-Anne, you want to start off with that, or?
Could do. I was actually going to go with
Or
Max.
Chris, Dr. Vitek?
So
Dr. Vitek?
the important part here is knowing who's where and knowing whose strength, where the strength and capability is, and build a connection. A number of in some situations, you may read an article and realize from a peer review article, oh, I know where this person is. And I'm going to ask that question. We're going to coordinate our work based on the similarity to what we present. So if I want to do something on ticks, I'm going to now chase down Dr. Sarah Gunter because I know where she's at, right? I'm going to try to chase Dr. Hammer because I saw she did something on ticks and birds, right? Birds traveling across Texas, transporting ticks. So I because I have a tick, we have a tick program, I can go in that direction. So the collection, to get this information, we need to know who's where and what's the strength and capabilities and the willingness to attend. And either way, mosquitoes, whether it be meat flies, whichever it is, we know who's where, and you connect with that individual and get that information across. And what you will find, one will find is that it is always so very pleasant and folks are always willing to contribute to each other's development.
Do you want, Leigh-Anne, you want to talk about the malaria? Once we identify we had local transmission, it wasn't traditional trapping like we usually do, and it wasn't traditional testing like we usually do. You want to talk about what was done, the jurisdictions that were involved?
Yeah, so it's for control measures, it's always going to fall to the local jurisdiction. It's their responsibility to have these measures in place. If they don't, they can definitely find me. They can call the state, region. We're all here to help. DSHS is here to help with that. It's obviously a unique situation when you have malaria, when you haven't in 20 years or so. So a lot of collaboration goes in with state and local jurisdictions. And we came up with trapping that was a little bit different than what they would normally use down there. As they suggested, Aedes aegypti is mainly what people are looking at. You would tend to use a different trap for that than you would something for an Anopheles mosquito or a general collector, just seeing what's out there, just trying to grab what you can, and that's a CDC light trap. You can use an EVS or anything to that effect. You can also use BG traps with CO2. It becomes then a general collector. So you've just kind of modified it a little bit. You're going to use different areas than you typically would. If you're looking for a different mosquitoes, a different vector, they're going to like different ecologies. They're going to like have different habits. So that's where you're going to kind of change everything. So we have a discussion with your local areas, your all your partners, so your universities in the area, kind of make up a little bit of a plan and set those out. So we brought out some of these resting boxes. We tried to make some resting traps because we could not find them anymore. Sorry, BioQuip, rest in peace. So we set these boxes out. Hopefully that would help us collect any anopheles that would be in the area. It was a very urban area, so it's typically not going to collect a lot. There's a lot of competing habitat. So we were pretty unlucky with that. We did get CDC trap specimens, I think, at the state in Dr. Bethany Bowling's lab. And they pulled them up. They sent them to CDC, I believe. They identified them and then sent them on to CDC.
CDC and the CDC, they tested them for plasmodium via PCR in their salivary glands, I think, like specifically.
And they're,
And then they tested for blood
yep,
in their guts. Blood and guts.
yeah. Yeah, so those are all the intricacies of, I can't speak now, sorry guys, of who all is involved. So you've got universities, you've got local jurisdictions, you've got state, and now you've got CDC as well. So everybody kind of has this big handshake. We all work together and get a control plan down.
And we had like three municipalities that were involved where we identified what we think is probably our index case, the locally acquired case, and then the place where we think the locally acquired case acquired at that municipality, and then where that locally acquired case was staying. So surveillance activities were held at those three municipalities in that county, and so all three of those municipalities were on trapping, doing this special type of surveillance. I can't remember. Did we do that for 6 weeks after the case identification? I can't.
I think they extended to a little bit longer, just for precaution. I believe
Okay.
It was.
And then on the surveillance activities, like I said, we usually see Aedes aegypti, well over 60% of our, and anopheles, a big mosquito. So we're trying, like, how do you catch an anopheles? So we were relying on researchers' publications on best traps. What type of surveillance and monitoring tools would you guys like to? Oh, sorry, I went back. What are the benefits and challenges in coordinating response activity? The last part. What are the challenges, benefits? I think probably one of the challenges is like when we're doing surveillance at a place, we can't give a specific address. And people are like, well, I want to know where they lived. Like, no, I can't give a specific address. We can give you an area where they were. But, so that's a little bit. But and then benefits of it is I get to learn a lot about mosquitoes, insects. Probably just sharing of knowledge, and what Dr. Vigilant said, the pushing of educational activity, get a lot of bang for your buck, and we drop the cases. All right, so the next topic is vector distribution. How have the population distributions of mosquitoes that carry illnesses such as dengue, West Nile virus changed over time? And how might the ecological or climate changes affect a community's risk for outbreaks or arboviral diseases? And how important is it to monitor mosquito populations?
So I think we were all familiar with the dengue vectors and the tried and true albopictus coming in from South Texas here in this area. And it's now pretty much spread throughout the entire state. So yes, there is a distribution change that can happen. It doesn't necessarily have to be climate because it's pretty hot down 100% of the time down in South Texas. But most of Texas is pretty warm. You might see some changes up in the north side that might be more welcoming to different vectors and different reservoirs that could bring in vectors or create new vectors. It just depends. So they might bring in that pathogen themselves. So there is a little bit of a change that goes on there. We have a big influx of populations that can go in and out. We do like to travel. So coming in and out of endemic countries, you are now bringing in some of these pathogens, and you could be the reservoir yourself of dengue, malaria, as we have seen in the last couple of years. But we're building into some of our habitats as well. So people that call in and they're, oh, we've got mosquitoes, can you come out and spray? I just wanted to build my house in a quiet area. Well, you've just taken into their habitat. So sorry you're outside. No, nature happens. Apologies. So that's another risk that could be happening to expose humans to pathogens and vectors themselves. So what was the last part of the question? Sorry.
Well, I'd like to
How
add something if I
important is
can.
it for?
Please, yeah.
Yeah,
for
so one other thing I'd mention is it's not just spread of the vectors, but also changes in patterns when you see them. And so, I mean, down in South Texas, historically, we're so hot in the summer that mosquitoes don't even like it then. So we
Yeah.
see a drop in mosquito activity in the summer, but this past summer was very mild. So we saw much more continual activity. And so that just highlights the importance of the surveillance and knowing when they're going to be active, because that's ultimately going to tell you when there's disease risk as well.
Yeah, yep. Okay, so then the last question that we have to discuss, I'm getting us out of here early, maybe. Border communities. My region is South Texas, 19 counties, but it borders, goes up to Laredo, down to Brownsville. And so border communities, we know zoonotic illnesses don't recognize borders. Those mosquitoes fly right over the border. How do public health practitioners protect communities with dynamic human and vector populations, such as at the border? And then are there challenges specific to monitoring and responding to arboviral threats in the border communities?
Yeah, so living there on the border, I can tell you that there are some unique situations there, and those two questions sort of go hand in hand. You can always sort of say resources. I think that's probably a universal challenge wherever we are, but certainly funding for surveillance efforts for regular trapping and that kind of thing is important. We also have a very large population of at-risk community individuals, people living in impoverished areas, don't have access to full facilities, even things like running water or electricity in some areas, trash pickup, and a lot of times that can just enhance or increase the breeding areas. But it also means that there's a large number of people that don't maybe have adequate medical treatment, adequate medical care, or facilities that they can go to. You mentioned that they sometimes don't even go seek treatment if they know it. So a lot of times there's concerns about accurate reporting, accurate numbers that are coming forth about the case counts and so forth. Certainly, I know I'm a professor. I know a lot of my students do this. There's a lot of travel across the border for medical reasons where people will go because they don't have health insurance, because the costs are too high. They'll go across the border to seek treatment. They'll go across the border for diagnosis. So who knows how many cases might be slipping through and being undiagnosed from that perspective. And so that's, again, in terms of surveillance, in terms of trying to identify what's going on, those are some major issues. As you said, mosquitoes don't recognize the border. I always joke around that mosquitoes are happy to fly across the river if they're able to, or if they can't, they'll hitch a ride with someone in a car or something along those lines. And so in addition to introduction of new pathogens, like some of these new diseases coming around, there's also potential introduction of new species, invasive species that could be vectors of new disease as well. So a lot of that, it requires cooperation on international levels, working with partners in Mexico, working with public health agencies there to see what's going on, to be aware and monitoring situations in those regions that are adjacent to us, because it's no longer just a situation of what's happening in a nearby county, what's happening in North Texas. It's now an international kind of boundary. And that also then presents potentially some legislative issues, some issues of who has jurisdiction in certain areas and so forth. So I would say, I mean, those are sort of the primary challenges that are being faced. I will say that we have a lot of great people in vector control, environmental health down there that are in many cases reaching those challenges, that are able to accommodate those challenges, but they're always present. There are always going to be concerns related, especially as we have new diseases coming in.
Can you like, I'm curious, like with colleagues, research colleagues in Mexico, like in Reynosa or something like that are doing mosquito trapping surveillance, like maybe if they got up a new resistance testing process and you wanted to send mosquitoes over to there, would you be allowed to just take mosquitoes over there or like?
So yeah, so unfortunately, even just transporting mosquito specimens, even if they're dead, can be a really paperwork intensive kind of effort. You need all sorts of permits, you need approvals, whether you're bringing them aboard or bringing them across onto our side. And it's one of those things where legislatively it can be very time consuming and ultimately disheartening effort to try to pursue if you want, unless you have that time and ability to do so. It can be a challenging, it can be challenging to try and pursue that just because of the forms and paperwork. I've tried to import mosquitoes from different countries around the world, and I can't even count some of the numbers of forms that I've had to fill out for some of these, even for ones that are not vector species or anything. It's just, there's always that concern of introduction of something.
It's interesting because like, you were talking about people go across for medical care. People take their pets across for medical care too. Like veterinary care. What if you take a mosquito across?
Yeah, I mean, we're talking about mosquitoes, but certainly other ticks and stuff like that as well.
Needs a blood transfusion.
I wanted to add a little bit onto what Dr. Vitek was saying. So we've talked a lot about the role of the local public health jurisdictions, and I feel like that's so extra crucial at the border. The folks that I've worked with and heard present and worked with on investigations in South Texas, they know their community better than anyone else. Their community trusts them. They would not trust me. Why would they trust me? They don't need to talk to me. It's very important, our role kind of on that public health hierarchy at the state or at CDC is to help provide that really persnickety disease expertise. And then our role is also to step back and make sure that the people working in their communities, can advocate for what is going to work in their community. So when we say, okay, here's a 4-page document about the correct way to diagnose dengue with appropriate lab testing, it may be that complicated because it is. It's like trying to pin a needle and get a needle out of a haystack. It's really, really hard to confirm dengue if you don't use the appropriate test at the appropriate time. I was talking about those different flavors of dengue. The immunology of that disease is very complicated, especially if you've had repeated exposures. So providers in northern Mexico, well, throughout Mexico, but folks who go across the border to seek medical care, those providers know dengue like instantly. They look at them for 20 minutes and they are confident that person has dengue, and they're usually right. They usually do the right testing, or they say, you have dengue, don't take Tylenol, call us if you feel worse. If you have these symptoms, go to an ER, because there is no treatment but supportive care. Whereas even sometimes just on the other side of the border in Texas, some of our providers may not be as aware of the nuances of that testing, and they may misdiagnose simply because they run what they think is normal testing and they're, IgM is negative, it's not dengue. And that's not always that simple with a disease like that. So I think it's so important that that provider education piece and working with their community and their public health prevention community, especially when this population, folks they know that dengue is around. They know it's just kind of an exposure and a part of life, just like West Nile is for the rest of Texas. But they're not going to not see their family or not go to the doctor that they can afford just because dengue might be around, when they go across the border. So I think it's very important to understand the nuances of, our border Texans and respect, that way of life is the border's awesome. I love being down there. It's really fun, and you can eat the best food in your whole life. But yeah, it's our local public health folks down there just doing awesome work.
Yeah, and I would also add, I think it was Paul, he's not there right now. I think point him out there, but I think he mentioned about some of these symptoms for diseases, how he sort of classifies them all similarly. And so sort of along those lines, the healthcare practitioners and they need to know what the local diseases are. They need to know what is at risk in those regions. And so again, that's where some of these public health offices can really be beneficial with that educational effort as well.
Yeah, I'll add a little bit to that. Our local epidemiologists, they do such a great job. And then, like I work with them and I am giving them information. I'm pushing them information that Kelly and Bonnie and Mariana and Kamisha have made for me. And so I'm just reviewing it, making sure they're aware of it. And it's really, really important that that nuance on that, getting that specific onset date. Okay, we're dealing with this type of test. We have this kind of window that we need to look at for travel history. Like an IgM, we've got a bigger window versus a PCR. And, sometimes they have to work with like explaining why it's probably clinically a case, but we're not going to record it because it's not meeting our mathematical epidemiology formula that we have to follow. So we probably do miss a fair amount, but well, we've gone through this quick. Before I forget, do we have questions online from our?
We do have, hi, I'm here in the back monitoring online questions. Hi. We do have several online questions. There's a couple of questions I'm going to combine into one. It's around the Mpox, avian influenza, and West Nile virus. I think there's just interest in sort of understanding what the predictions are for these three diseases, if there's going to be if we see more cases, particularly with Mpox and avian influenza, are there going to be new variants forming? Are there going to be any mutations predicted? And sort of also what the impact of Hurricane Beryl has been on West Nile virus. I'm going to start with that.
Yeah, I don't think we'll address the Mpox or the avian because there's going to be a panel about avian influenza. But we can probably talk about West Nile virus, like, I don't know if it's impact of a Beryl or just the general rain, or what's your thoughts on West Nile?
Well, we have had a pretty mild winter the last cycle, and the nuances of what allows what appears to be a cyclical increase in West Nile, and for reference, West Nile wasn't here, 26 years ago. It wasn't here. So we only have that many years of data of this disease existing in our very unique ecology. Texas has like 7 different ecological zones. So, we're a really fun mix of things. But there are some theories, none of which I'm an expert on. I'll certainly pass it to Leigh-Anne or Dr. Vigilant next, or really all of you know better than me about mosquitoes and what they're responding to. But weather patterns certainly make a huge impact. But also there could be some element of population immunity and exposure levels, population growth. Younger people are less likely to have been exposed. We think you only get exposed only infected once in your life with West Nile. So if you think of it that way, that kind of changes how you're perceiving that risk level for West Nile. But I'd certainly pass it off to my vector friends here to talk about that part.
I would also, not just humans, but also with the reservoir hosts of the birds.
Yeah.
Because you have situations where the birds, if they survive, then they're going to be okay. But then eventually you're going to have fledgling birds. And when you have enough of that susceptible population as well, that allows the West Nile to spread within the bird population. And as Paul was saying, we're not the primary targets. We're not the primary hosts. So it's when there's enough in the birds that is being spread by the mosquitoes that we then have that spillover into the human population, which then also corresponds with what our relative risk and immunities are and so forth. So as you said, there's all these sort of strong interplay between a lot of different factors.
West Nile virus birds are the amplifying host. If you're asking yourself, why is he talking about birds? Birds is the amplifying host for several of our arboviruses, West Nile, St. Louis encephalitis.
Yeah, in the case of say Harris County and Beryl, we had West Nile positive pools before Beryl. But what happens in the situation when you have a storm like this, you get 2 factors. You get washout and you get blowout. You get washout of any larvae that's in the ponds or in the pools or in the containers. You get blowout of the vectors. That was with Culex blown out of the area for a period of time. It takes another 7 to 10 days before you see another presentation of and propagation of mosquitoes. So you will see the numbers for West Nile will drop. So folks were saying that the that West Nile virus increased during or after burial. From our data, that was not true because we saw the numbers were lower. The floodwater mosquitoes were present. There's a nuisance that was just bothering everybody and killing everybody because they were present earlier than normal. But in terms of the Culex fasciatus, which is the main vector for West Nile virus, we had the washout, we had the blowout, so we had another period to wait for another couple of weeks before we saw the numbers increase. So the storm doesn't really increase, and it's in literature that floods and storm does not, at that time, you do not present with vector-borne diseases.
Any more questions online?
Sorry, yes. So there is a question about if a statewide list exists with subject matter experts for things like malaria, dengue, the things that we're talking about today, especially for folks who live outside of jurisdictions or who have trouble accessing information, maybe in more rural areas, et cetera. Sort of what tools are available.
Yeah, if you go to www.texaszoonosis.org, that will give you a list of the regional public health regions or public health region and the zoonosis control programs. But then for our university colleagues, I don't know, have any lists for, but we work with them all the time. And maybe we just make a list of registered experts, with Dr. Vitek.
Yeah, I think a lot of that, again, that'd probably be a good idea to make a list. I think
Yeah.
that's something that Department of State Health Services should get on there. So, but I think it's.
They got nothing else to do.
You're just sitting around twiddling your thumbs.
Yeah.
So.
There's one more question, just about, is there any sort of intention around trapping and testing for Eau-Couché fever, especially about what's happening here in the state? Is it present? What species might be here, et cetera?
Leigh-Anne, that's you.
Yes, there is intention to trap. I don't know if we'll be testing. It's more just like a preparation, if you will. If we have the capacity to even get species and just practice identifications and working with CDCs if they wanted to test these species that we do collect. So intention, yes.
And
Nothing
then
official.
do we have a question here? And
Yep. So, are we? So we did a bulk of the collection. I think I did a bulk of the collection from the table. And yes, we identify the species. So we will collect a mosquito, come to the lab, and we'll separate them. And we identify them to species. So we know it is Aedes aegypti, Aedes albopictus, if it is Tenorhynchus, or any of the Aedes species. We'll do the same with Culex. We'll do the same with Anopheles. We'll say the same with any one of the other species. Culicita, whichever species that is collected in the batch, in the net, we separate them by species, record them in the database, and yes, we do.
Yeah, and for a lot of the places that don't have the facilities to do their own identification, they do that at the state.
By state, yes.
Yeah, that is commercially available. So in the acute phase, PCR or NS1 are both great tests to include. Ideally, it would be either PCR and NS1, either PCR or NS1 and an IgM IgG panel, just for the nuances of the dynamics of immune response. A lot of providers don't even seem to know what NS1 is. I have to be honest. It's one I see very infrequently, but I reviewed a dengue case that was, it was a child whose family said, oh, I think our kid has dengue. They took him across the border. The doctor immediately did NS1. It was positive. And I used that lab report to report him as a confirmed case. So it's definitely something that I think there's a knowledge gap. And CDC dengue branch has recently made a lot more provider education tools available and really ramped up the education also of other health departments, because in Texas, we're well versed in dengue, but some of these other state health departments in other states just may not have the history of dealing with as many travel cases. So I think it's really a nationwide diagnostic issue in terms of just provider awareness, that it's not as simple as I suspect dengue, which is great. to suspect it, but then to not just pop on an IgM, IgG panel and call it a day, no matter what the timing is. So NS1 is used. I see PCR a lot more often though.
Plasmodium vivax. Something unique that I.
Sorry, can I interrupt? Can you please repeat the questions? Because the people online cannot hear the questions being asked in the audience. Thanks.
Oh, you have to go back to the first one.
The first question was about the
Not working.
It's cursed.
okay. My first question was about when you do vector surveillance, do you differentiate between the species? My second question was about the use of NS1 antigen for the diagnosis of dengue in Texas. And my last question is about the cases of malaria transmitted within the United States, if we know the species of Plasmodium involved.
Excellent. 1 minute. Okay. I have one joke I wanted to tell you. This is a joke that was provided to me. So I borrowed this joke from our regional medical director, Dr. Emily Pro. I give her credit. She's from France originally. What does a mosquito and the Eiffel Tower have in common? They're both parasites. That's a good one. I don't know. Thank you so much.
Are we ready to go? You don't go anywhere.
Oh,
Thank you, Kendall. Thank you. Thank you.
You can't go.
Okay, bad dad jokes aside. So thank you, Dr. Tyler, for the dad jokes and the panelists for an insightful and engaging conversation. Now, I would like to invite Dr. Sullivan to the stage. There you are. To present this year's Friend of TEPHI Award. Now, this is a tradition that we started last year, and I'm so happy to continue this tradition. Let me introduce Dr. Sullivan just very briefly. Dr. Brendan Sullivan is a regional zoonosis veterinarian for the Texas Department of State Health Services, Region 65 South, and he has supported this year's summit to a great extent, and he is here to present this year's Friend of TEPHI Award.
Hi, thank you, everybody. So it's my pleasure to introduce this year's recipient of the Friends of TEPHI Award, Ms. Leigh-Anne Lawton. Ms. Lawton, recently appointed the state public health entomologist, has demonstrated leadership and dedication in the crucial yet often under-recognized field of medical entomology. Since joining the Texas Department of State Health Services, Ms. Lawton has been integral into disease surveillance and control efforts across the state. She's trained and worked with local health departments from trapping and testing sandflies for leishmania in Collin County, horseflies for anthrax in the Panhandle, or assisting with mosquito trapping efforts for malaria in the Valley. I honestly don't know anybody who has traveled the state as much as she has the last couple of years. But her impact extends beyond day-to-day surveillance. When flooding events lead to an explosion in mosquito numbers, Leigh-Anne has been there providing technical guidance to localities requesting federal mosquito abatement assistance. After unseasonal flooding in a couple of smaller counties in our region earlier this spring, Leigh-Anne went out and trained county preparedness staff on how to perform the mosquito surveillance necessary to access those federal funds. She continued to keep in touch with the staff and the employees that she trained. And when Hurricane Beryl hit 2 months later, that county was one of the first to be able to submit their mosquito surveillance for funding. She was provided the training and mentorship needed to help build surveillance capacity in communities throughout Texas. For her tireless commitment to public health and her exceptional contributions to vector-borne disease control, we are honored to present the Friends of TEPHI Award to Ms. Leigh-Anne Lawton. Please join in celebrating her outstanding work.
Yeah, thanks. So, very chuffed to be here. So thanks so much. I don't know if he was actually talking about me, but it sounded really cool. So I'll take it. This looks really neat too. I hope this brings more awareness to entomology and the public health field. It's very lovely. Thank you. And if you don't have an entomologist in your program, you need one, here I am. I'm in the state. If you're in the state, I'm in the state. Let's go. Happy to help. Please reach out if you do need anything or if you have any questions about entomology in the public health region or anything like that. Thanks.
Here, I'm going to give this to you. There you go. I'll give you the box in a few minutes.
Oh, okay, thanks.
Okay, good. Great. Congratulations, Leigh-Anne. And thank you, Dr. Sullivan, for presenting the award. The issue with parking. So we have a deal. I am so sorry about this issue with parking. This event was much more popular than we thought it was going to be. So which is showing that we are serving a need out in the community. So really, thank you guys so much for being here. I am really hoping that some of the spots are opening up around lunchtime. So if you feel like taking a stroll out there, perhaps you can move your cars into some legal spots. But as long as you are not impeding the flow of traffic, we are told that nobody will be towed. Okay, so again, my apologies for the parking situation out there. So we are now serving lunch out in the foyer. We'll resume the program back in this room promptly at 12:30. And please have your raffle tickets in hand for a chance to win. And yes, you must be present in the room to win. Thank you guys. Enjoy your lunch.